All right, diving into another emergency medicine topic. This is LLSA 2021. We are talking about improving the management of severe asthma, BiPAP and beyond, by Bayal et al. Matt DeLaney hooks up.
It's a nice little paper. The bottom line is that asthma can kill people, and we have some tools to try to stop it. Specifics here. So a lot of this is a rehash of various guidelines. So most of what they recommend here is per the National Education and Prevention Program guidelines, the NAEPP. And they say, look, if you have asthma, there are three main treatment goals. One is the correction of hypoxemia. The second is the rapid reversal of airway obstruction. And the third is reducing the likelihood of relapse. The background here, 8.4% of pediatric patients in the U.S. have asthma. Again, this paper is largely focused on the pediatric population. These kids account for 600,000 annual ED visits. There are 322 deaths in 2014 looking at patients under 25 years of age. And they talk about these two near-fatal asthma phenotypes, which I don't know has a whole lot of applicability to the patient in extremis in front of us, but there's the insidious patient where they have this kind of worsening of their symptoms over hours to days, and then the rapid progression. I was fine until I wasn't, and now I'm decompensating in front of you. So it's a problem. Fortunately, it's rare that this is fatal, but it's certainly out there. So they kind of guide us through things we can do to try to treat these patients and improve outcomes for the patients. When it comes to the treatment, a lot of this is familiar. I think it's a good refresher, though. So inhaled beta-2 agonists, albuterol is what we're talking about here. It's first-line therapy. And remember, this is a short-acting beta-2 agonist. The abbreviation is SABA, S-A-B-A. And I think we all know albuterol works by directly relaxing bronchial smooth muscle. This relieves bronchoconstriction, and the dose is going to be 0.15 to 0.3 mg per kg, up to 10 milligrams every 1 to 4 hours as needed. Ipratropium bromide, this is something a lot of us, I think, combine this with our albuterol, but remember, that's an acetylcholine receptor antagonist. It binds the muscarinic receptors on the smooth muscle. Again, this will decrease bronchoconstriction. It's often used in combination with the short-acting beta agonists for severe exacerbations, and the dose on this is 0.25 to 0.5 mg every 20 minutes for 3 doses, then every 6 hours is needed. Corticosteroids are a mainstay of treatment. They decrease airway inflammation. There's actually some synergistic effect when you combine these with the beta-2 agonists. There's a lot of debate about what type of steroid is best, how should we give it, and these authors, I like that they say the oral route is as effective as IV or IM, because if a kid will take it by mouth, let them take it. They say that in terms of dosing, there's no need to dose greater than 2 mg per kg. And they say, look, if you like methylprednisolone, it's 2 mg per kg IV with a max of 125. Prednisone is 1 mg per kg, a max of 80 milligrams daily for 5 days. I will say clinically, that is a very high dose for anyone to tolerate, but that's what the recommendations are. And the dexamethasone is 0.6 mg per kg for a maximum dose of 16 milligrams PO, and then a second dose, same strength, on day 2 if the patient is discharged. So steroids help. It doesn't really matter the route nor the specific type of steroid we choose.
Yeah, and my clinical translation of that PO versus IV-IM, I'm going to go PO with the majority of my asthmatics, the ones that are sitting there, being able to hold their own nebulizer, and they can swallow pills. And then it's obvious those that are huffing and puffing, there's no way they're swallowing a pill. That's where I'm going to be doing my IV-IM. And so I agree with you. I like the fact that we know PO is as good as IV-IM. It just really depends on the patient's ability to swallow.
Yeah, and I was always taught that for prednisone dosing, it's give a double-digit dose in milligrams for a single-digit number of days, and don't get lost in the weeds. So they give us some good options here. We can pick our favorite, use that for the next asthmatic. Those kind of first-line agents are what we use for moderate, folks who look okay in front of us, and then they kind of walk us through, what if that doesn't work? So what if it's severe or an unresponsive exacerbation? And then we're looking at stuff like a continuous beta-2 agonist nebulizer. So this is 0.5 mg per kg per hour. When we're doing this, these kids are sicker, so we should be monitoring them more closely, but we have to think about things like hypo K, dysrhythmias, tremors. You can get diastolic hypotension, lactic acidosis. These are fairly rare complications, but they can occur. And the thought is if we have a kid with severe or unresponsive exacerbations, if we hit them with these continuous nebulizers, we may actually turn some of these kids around and reduce hospital admissions. IV magnesium sulfate. I feel like magnesium sulfate was the belle of the ball a couple years ago. And the evidence is a little bit mixed, but the basic idea here is that MAG is going to enhance bronchodilation. And the evidence is strongest that we use this for severe cases, and the impact seems to be that if you have severe asthma and we give you IV magnesium, we can reduce the incidence of hospitalization. Not saying it doesn't work in other kind of disease, other presentations of severity, but that's where the evidence seems to be, is that reduction in hospitalization. The dose is 25 to 75 mg per kg per dose. You max out at 2 grams over 20 minutes, and you want to watch for hypotension. Is the only real complication you get from this. That stuff's not working. We're going even further into our bag of tricks. Epinephrine and terbutaline. Epinephrine, if you talk to folks who have done this for decades, that's what they used before they had albuterol. I think of it as something as kind of a last-ditch effort, but it actually is a decent agent. So it's going to relax the smooth muscle. And in this guideline, they say specifically this should be used if we think the patient's wheezing from anaphylaxis. So that's kind of a diversion. We're thinking asthma. This paper is about asthma, but they say, hey, look, other things can make you wheeze. Anaphylaxis being a big player in the other things that make you wheeze. So if you think it could be anaphylaxis, or if the patient can't use inhaled short-acting beta agonists, if they, for whatever reason, can't tolerate albuterol, reach for epi at a dose of 0.01 mg per kg, maximum dose of 0.5 milligrams IM.
You know, Matt, this is a really important clinical point that I've been doing since my training really is, look, yeah, anaphylaxis, we know that. And then that patient, like when the patient can't use inhaled, a short-acting beta agonist, there are some patients where they're going to roll into your emergency department, the ones that are diaphoretic and really unable to take deep breaths. You just see them. You can see them tripoding, where I'm going straight to the epinephrine because, yeah, I'm going to start the nebulized meds, but I know it's not going in their lungs. And so there are occasions, and really this is a crashing and burning patient that I'm trying to avoid intubation on, where I'm going epinephrine IM up front with my nebulizer and with that other stuff, because you can really just turn around like you can with anaphylaxis patients, or at least give you that time to get the other medications working.
That's a great point. And I think this article breaks it down as a stepwise progression, but I think the reality is exactly what you said. If someone's crashing or even moderately sick with asthma, we're doing a lot of this stuff in parallel. And I think we have this fear of, oh my gosh, epinephrine seems like a big drug to use. And it is, but these are children that can handle this pretty well. And I've had many kids turn around with epinephrine. One of the things that I have not given often, which I actually may start using more, is terbutaline. It's a selective beta-2 agonist. You can do sub-Q dosing at 0.01 mg per kg per dose. You max out at 0.25 milligrams. Every 20 minutes for 3 doses. You've got an IV dose that you give by a continuous infusion as well. So epi and terbutaline are options that are effective that a lot of us might not reach for in some of these cases. So the Pearl, epinephrine IM, is the first-line treatment for anaphylaxis. Huge pearl of this article, something to think about as we think about the test. But also, like you said, I think there's a role for epinephrine IM in an asthmatic that goes beyond anaphylaxis. But these authors really want us to think wheezing might not be from asthma, could be from anaphylaxis, and the treatment there is going to be IM epinephrine. Then they get into other meds for severe asthma exacerbations, and their recommendations here are a little wacky. So there are several things they don't recommend, and most of that is based on the fact that the overall kind of quantity and quality of evidence isn't really there. Not necessarily that these things don't work or haven't been shown to work in some smaller studies. So inhaled Heliox reduces airway resistance, may decrease hospitalizations. They say that's an okay thing to use. Ketamine, which is something that I was trained to use this in asthmatics. This is what I use to induce asthmatics if I'm going to intubate them, because you get these bronchodilatory properties. The patient stays awake, they keep breathing. The NAEPP, or the Global Initiative for Asthma, the GINA, say that they don't support the use of ketamine. I would personally disagree with that, but they fall back on, hey, we just don't have sufficient evidence to say that this is effective in pediatric asthmatics. Aminophylline is a bronchodilator. It can improve diaphragmatic contraction. This is one where they say, hey, listen, do not use this. The side effect profile is too worrisome. So I don't think most of us are reaching for this, but these guys say, out of all these drugs, do not give this because of the potential downsides. And then inhaled anesthetics. So typically this is an out of the ED problem. This is somebody with refractory status asthmaticus. I've done everything. They've gotten every drug I have. They're in the ICU. We have anecdotal reports. We have smaller studies that say, hey, this is effective. But these authors say, let's be honest, there's an overall low quality of evidence. So they don't fully recommend this just based on the lack of evidence. Then they get into respiratory support for severe asthma exacerbations. Interestingly, the NAEPP says any non-invasive ventilation is experimental. And I had to read that a couple times because that seems crazy. But again, I think they're just taking a very conservative approach with the recommendations and saying, look, we just don't have big, high quality, well-done studies to show that these tools work. Things that a lot of us have used, especially since COVID's come around, high flow nasal cannula works great. It bumps up your FiO2. You get some PEEP from it. The idea here is it can prevent this escalation to non-invasive. I mean, I don't want to tube a kid if I can avoid it. Kids don't like face masks, so this is really a less invasive, non-invasive way. The issue here is that there's not enough evidence for them to recommend this formally. So they don't say we can't use it. They just say we can't throw our weight behind this. And then you talk about CPAP and BiPAP. You know, the benefit here is the patient's awake, they're cooperative, if they can tolerate it. And what they say is that this may be something to use if the patient has increased work of breathing, if they have hypercapnia or hypoxemia, and they start at 10/5 centimeters of water for BiPAP. The pitfall here, again, they say you can use CPAP, BiPAP, yet we're not recommending any of these non-invasive. They're all experimental, but they say if you're going to use CPAP or BiPAP, you have to think about the contraindications. So if the patient has hypoventilation or loss of respiratory drive, if they're unable to protect their airway, or if they're having respiratory or cardiac arrest. And I think that makes sense because I think of this as a tool to help them do what they're trying to do, which is breathe. So if they're not breathing well, if they don't have that drive, if they can't protect their airway, they're not breathing well. And if they're in cardiac arrest, they're not breathing at all. Those would be absolute contraindications to using CPAP or BiPAP.
Yeah, man, I couldn't agree with you more. That really is the non-invasive stuff. Yeah, it's experimental, but we know it's not going to hurt them. Where I think it can hurt them is where we may rely on it too much. Be like, oh yeah, I'm just going to try that first, and not recognizing really that patient that's circling the drain. And that's just, it's not going to buy you any time in this situation where it might in lots of maybe those moderate patients. You got to sometimes just bite the bullet and intubate this patient. As much as we fear that in asthma, sometimes it really is the only answer if they're not responding to your meds and they're just too sick for the non-invasive ventilation kind of strategies.
This is Hippo Education.